I'm going to concentrate on three major objectives. One is that we're going to review the prevalence of poor sleep in people with HIV, and also delve into some clinical consequences of poor sleep in people with HIV. And then lastly, I'll be spending the bulk of this talk exploring different biological pathways that are common to both HIV-associated inflammation as well as sleep disorders, mainly concentrating on T lymphocyte subsets, purinergic signaling, and then my preliminary work in monocyte activation. And so, first of all, I want to make the point clear that poor sleep health is extremely common in people living with HIV. Differences in sleep disturbances have been reported pretty prevalently, and even though each study defines them differently, the prevalence of sleep disturbance is estimated to affect up to 70%, up to 3/3 of people with HIV. And that's not just limited to obstructive sleep apnea, but really across all domains of sleep. Regularity, duration, circadian timing, variability, satisfaction, sleepiness. And you can see the rates up here. Overall, people living with HIV tend to have a reduced total sleep time compared to people living without HIV, tend to have reduced sleep efficiency, more frequent awakenings and disturbances, and disorganization of rest activity patterns, really variable sleep patterns, as well as delayed circadian timing.
Priya,
Yep.
we're stuck on the objective slide here on the screen on the presentation.
Let's see. Maybe if I just do this.
Yeah, that's fine.
How about that?
And then just click through when you.
All right.
Okay, good.
We're just gonna do it the old-fashioned way. Okay.
I get rid of this thing.
Can you see the slide now?
Yep.
Okay. And so, but yeah, the fact remains that there is still a very high prevalence of people with HIV having obstructive sleep apnea, and it can be defined in a variety of ways. But this recent study by Chris Schmickel et al. In 2022 reported that by the conventional ASM criteria, up to 2/3 of people living with HIV had any severity of sleep apnea, whereas by Medicare criteria, it was still over the majority of participants having sleep apnea. And the reason behind this is due mainly to the rising rates of obesity that we're seeing throughout the nation, but that includes people with HIV. People with HIV are living longer, and so they're prone to the traditional risk factors. There was a thought that perhaps people living with HIV had differences in physiological traits that might make them more vulnerable to sleep apnea. But a recent study that was also published by the UCSD group showed that there weren't any differences in measures of loop gain, collapsibility, arousal threshold, or the other endophenotypes. And so it appears that people living with HIV with obstructive sleep apnea have the same physiological traits of their obstructive sleep apnea as that you would expect with people without HIV. And so the reason that poor sleep is so common in people living with HIV is really through a multitude of risk factors, including social, medical, and environmental risk factors. People living with HIV are at high rates having HIV-related stigma and discrimination that can certainly affect their sleep quality and their sleep duration. There's a substantial part of this cohort that suffers from unstable housing, history of trauma, and social isolation. And then there are medical reasons as well, such as the increasing rates of obesity, as I mentioned before. HIV-specific medications like Inference can also impact sleep quality. Inference in particular has been very strongly associated with insomnia. But levels of lipodystrophy that have been implicated in increasing rates of obstructive sleep apnea in this day of antiretroviral therapy really isn't a significant factor at this time. And so the reason that poor sleep for us can be very, very important to screen for in people living with HIV is that it can be a great predictor of poor outcomes in people with HIV. One thing that has been strongly associated with insomnia are levels of antiretroviral therapy non-adherence. And so you can imagine if people living with HIV aren't taking their antiretroviral therapy, then they're going to be at risk for poor outcomes, right, of AIDS and other comorbidities. But even in addition to not having great adherence with their antiretroviral therapy, insomnia can also be associated with greater rates of suicidal ideation, unemployment, use of illicit substances and other substance abuse, and a decreased HIV viral load. And certainly, insomnia has been associated with increased rates of depression and anxiety, both in men and in women without HIV. In this study that was part of the MAX cohort, the multi-AIDS cohort study, they followed 2,500 participants over the course of 10 years, half of which were HIV positive. And they asked these participants if they currently had bothersome sleep, and also had them take the CESD, which is a 19-item scale to measure depression, and those who scored a 16 or above were classified as having a sleep disturbance. And so you can see that people so in the dashed line here, you can see that the dashed line represents people with, so this red dashed line is people with HIV with a sleep disturbance compared to the thick red line, which is HIV positive without a sleep disturbance. And these people had 1.5 greater risk of having depression if they also had a sleep disturbance. And so the other thing that I think is quite interesting is, apart from social behavioral factors, we also do see a strong overlap in the medical conditions between chronic HIV infections and those comorbidities commonly associated with sleep disorders, such as diabetes, cardiovascular disease, and stroke. In the day of antiretroviral therapy, we're seeing far fewer deaths related to AIDS-related disease, and really more related to non-AIDS related diseases that are associated with aging. These include cardiovascular disease, metabolic associated liver disease, and other non-AIDS related cancers. And cardiovascular disease flips as being the #1 or #2 killer of people living with HIV, who tend to have an increased rate of cardiovascular disease above and beyond the general population, even when controlling for traditional risk factors such as smoking, dyslipidemia, obesity, and other traditional risk factors associated with cardiovascular disease. And it's thought that there is a chronic immunoactivation profile, a persistent immune dysregulation that's setting up these people for increased risk of these aging-related complications. And it's thought also that this might be going on with people with sleep disorders that are prone to these same comorbidities. And indeed, what we have seen in some studies is that people with HIV who have higher levels of sleep complaints are at higher risk of these comorbidities compared to people with HIV without sleep complaints. In this study that was put forward by the Veterans Aging Cohort Study in 2019, this study asked people with HIV at one point in time if they had bothersome sleep and to quantify how bothersome their sleep was. And so this y-axis here is the percent of freedom from a cardiovascular event since the index question, with the years of follow-up on the x-axis. And so you can see here in the light blue, people who had frequently bothersome sleep had the highest incidence of a cardiovascular related event compared to those who had no difficulty falling asleep, which was up here in the black. And so they were at 60% higher risk of having a cardiovascular event. And so the question is poor sleep in itself just a bad prognostic factor? Or is there something biologically that's happening such that the co-occurrence of HIV infection plus the additional stress of sleep dysregulation together heighten an underlying immune dysfunction? And that being said, it's difficult to really tease that out because poor sleep is associated with differences in social behavioral factors that can lead to poor HIV control and therefore developing, higher rates of immune dysregulation, and also psychological stress, which has independently been associated with greater vascular wall stress and inflammation. But here are some possible immune dysregulation mechanisms that have been posited to occur in people with HIV who otherwise have well-controlled HIV with well-controlled CD4 counts, compliant antiretroviral therapy, and aviremia. That despite being on antiretroviral therapy, there's this persistent immune activation. And I don't know if you can see my my cursor here. But the things that we're going to be talking about today are one on the left, persistent T cell activation and how, certain ways that we can measure that. We're also going to be talking about a pro-inflammatory microenvironment, particularly with the purinergic signaling pathway. And lastly, we'll delve into a little bit about evidence of monocyte activation. And that's what my main research interest is in, is kind of investigating these possible immune mechanisms that really kind of combine this potential synergy between sleep disturbances and chronic immune activation in people living with HIV. And so first of all,
Priya, can I ask you a question right here at the end of this intro here? You haven't mentioned the term either sleepiness or fatigue or particular symptomology, because the fatigue part would be very intriguing, given that this is a viral infection that's persistent, if it does give you persistent or differing levels of fatigue.
And I think that's a really good point. People with HIV do have higher levels of both fatigue and sleepiness, but certainly they do have distinct differences. But there certainly are increased prevalence rates of both HIV-associated fatigue as well as HIV-associated sleepiness. Absolutely.
Thank you.
Absolutely. And so when we talk about T lymphocyte subsets, there's a variety of ways to evaluate T lymphocytes. There are measures of immunoactivation, exhaustion, senescence. One relatively accessible measure or surrogate measure of immunoactivation and possibly immunosenescence can be measuring the proportion of CD4 T lymphocytes to CD8 T lymphocytes. I don't really have to remind people in this room the importance of CD4 counts in people with HIV. And as an outsider, coming into this realm, I had always thought, well, if the CD4 count is good, then what else do we have to worry about? But really, there's emerging evidence that despite having a well-constituted CD4 count, having a proportion of CD4 T lymphocytes to a higher proportion of cytotoxic CD8 T lymphocytes can predict worse outcomes in people living with HIV. And it's thought that this phenomenon is due to a relative shift in chronic immune activation that's persistent in people with HIV with the higher circulating T CD8 lymphocytes. And so I think that this study published in 2014 did a really good job of really summarizing the increased risk of various non-AIDS comorbidities that people with HIV are at higher risk for if they have a lower CD4 to CD8 ratio. And so generally we'll say that a CD4 to CD8 ratio less than 1, an inverted CD4 to CD8 ratio, is the highest risk, but certainly having a lower CD4 to CD8 ratio increases your risk of these comorbidities overall. And so you can see here that cardiovascular disease is part of that comorbidity risk, increased risk of stroke, as well as non-AIDS related malignancies. And so there has been some studies in the past that attempted to evaluate this relationship between sleep and T lymphocyte counts. Certainly, we have research in mice that if you acutely sleep restrict them, that the T lymphocytes, at least for a short time, will be relatively depleted before being reconstituted. And again, you know, in people, in humans, we also have a similar research that if those people undergo acute sleep deprivation, that there's a dampening of the peaks and nadirs of circulating T lymphocyte counts, both in CD4 and CD8 counts. But it's unclear if this phenomenon also extends to people with chronic sleep disturbances, particularly in people living with HIV. And unfortunately, the literature right now is very limited in terms of how it has recruited people living with HIV in the past. For example, in this study supported that people living with HIV with shorter sleep duration had lower CD4 T cell counts compared to those with a typical duration of sleep or even extended sleep. However, one of the things that the study is limited by is that 30% of the cohort had active AIDS at the time of the study. And so one would imagine that if you had poor HIV control, you would have increased risk of HIV-related fatigue, sleepiness, and derangements in your sleep duration and sleep quality. And so we wanted to investigate how CD4 and CD8 counts related to poor sleep in people who otherwise had virally suppressed HIV and were on continuous treatment. And so we took advantage of the multi-AIDS cohort study for this study, and we limited our inclusion criteria to HIV-positive adults who were virally suppressed and on ART for an extended period of time, who also participated in the MAX sleep study. With that inclusion criteria, we were limited to 289 participants. We took a look at several exposure variables, mainly that were acquired through an at-home polysomnogram. We took a look at total sleep time, sleep efficiency, and then we also wanted to learn more about the relationship between sleep duration and T lymphocyte counts. And so we also took a look at sleep stages, N1, N2, N3, and REM. And we controlled for the following covariates, as you can see.
Can you explain a little bit what that multi-center sleep cohort is? How many centers and
Sure.
Mostly academic or what?
So, you know, I forget exactly how many centers there are. There's at least 4, if not 6, that include Columbus, Ohio, Miami, Baltimore, California site, and the MAX cohort has actually been ongoing since the 80s. They've had 4 waves of enrollment during that time, and it's been a longitudinal following of people living with HIV since that time that it was originally constructed.
And the home sleep study was type 2?
The home sleep study was a portable study. It was the Knox device.
I see.
That was performed. It was read at a central reading center in Miami.
It was Knox T3S. It probably had a EEG lead on it. Okay.
It did. Yeah. Yeah, but it had a EEG lead as well as a chin lead as well.
Okay.
And so in terms of the participant characteristics of these 289 persons, they were all men. At this time of the max cohort study, it hadn't been combined with Ys. The women's cohort, the Ys cohort, is currently being studied with the sleep study, but this study is limited to men, so I do want to make that clear. And overall, these were middle-aged, primarily white men. And as you can see, both CD4 and CD8 T lymphocyte counts were really well constituted, with a CD4-CD8 ratio straddling that 1 number, as I was mentioning before. The time between the sleep study and blood draws was not necessarily on the day of the sleep study, but in the majority of participants, they had their blood draw within 2 weeks prior to the sleep study. And 90% of participants had their blood draw within 3 months of the sleep study. And as you can see from the sleep characteristics, these are similar reportings that we've seen in other trials, such as MESA, where they had a somewhat low sleep duration of 6.2 hours, an average sleep efficiency of 93. And what I will mention here is that the N3 proportion of sleep was very, very low, which we think was due to a limitation of the NOx-T3 device to capture slow wave sleep and delta waves. Overall, this was a non-sleepy cohort, although they did have they did relay sleep disturbances through their PSCI scores. And so when we took a look at at sleep duration, what we found is something quite interesting. So what you can see here in these black bars is that the CD4 counts, despite whether you're having short, typical, or long durations of sleep, are pretty similar between the 3 categories. However, when we take a look at this CD8 T cell count, it's the lowest at the longest durations of sleep, and it simply tends to be greater at a typical range and at a short duration of sleep. And so we can see this kind of expansion of CD8 T cell counts as sleep duration gets shorter. And in general, what we're seeing is about 30 cells per milliliter increase for every decrease of total sleep time. And then what you can also see here is that this gap between the CD4 to CD8 ratio becomes more profound with a shorter sleep time. And that's a little bit better summarized here in this right figure that shows that as the sleep duration decreases, the CD4 to CD8 ratio decreases. And so in order to understand this better, we also took a look at how sleep staging was associated with differences in CD4 and CD8 counts. And although we didn't see any differences associated with N2 sleep, N1, or N3 sleep, we did find a pretty substantial association with REM sleep duration. Here we divided REM sleep duration by tertiles, relatively equally proportioned. And again, at the longest duration of REM sleep, you can see that CD4 and CD8 counts are relatively equivalent and preserved. But as you go to the lower durations of REM sleep duration, this CD4 to CD8 ratio does become lower. And in general, what we're seeing is about 120 cells per milliliter of CD8 expansion for every hour of REM sleep lost. And so it's unclear, if this can be reproduced with actigraphy, and those are our next steps. But this preliminary data does suggest that differences in sleep duration and sleep stages may be associated with differences in CD8 T cell counts, and that would be really quite novel to the field. Certainly the CD4 to CD8 ratio is a readily accessible marker, but it's not a conclusive marker of measures of immunoactivation and exhaustion, which can be evaluated further with assessing HLA-DR, CD38, and other types of markers that are directly found on T cells. But I think that this is a preliminary first step that should be investigated further. We know that there are differences in the physiology of sleep over the sleep stages. There's certainly differences in hormonal regulation that might be affecting T lymphocyte homing and redistribution. And even differences in sympathetic activation can also activate and affect lymphocyte redistribution and activation as well. And so I do think that this is interesting data, although certainly needs to be investigated further. Moving on, we'll talk about some research that we're doing involving purinergic signaling. And I certainly don't have to tell this group that adenosine is certainly an important sleep regulatory substance that's been associated with the feeling of sleepiness and sleep pressure that increases with prolonged periods of wakefulness and decreases with periods of sleep. And this has been particularly found in the basal forebrain, although it's unclear if this change also happens more peripherally in blood and tissues. Interestingly, the purinergic signaling has been investigated a lot in the cancer literature, in which they take a look at the microenvironment of extracellular ATP to adenosine. ATP, when it's in the extracellular environment, is associated as a damage-associated protein. If there's cell-related damage, it releases its internal ATP in the surrounding environment and lets the rest of the cells surrounding it know that there's damage. Over time, that ATP ultimately gets catabolized to adenosine through two ectonucleosidases, one being CD39 and the other being CD73, ultimately to this extracellular adenosine. If you have an extracellular environment with a preponderance of ATP to adenosine, that's going to signal to the immune system that this area should be an area with increased inflammatory activity. It's going to recruit T cells and platelets and recruit cytokine production in order to clear that area of the insult leading to that extracellular ATP in the environment. However, if that ATP gets metabolized into a adenosine-rich microenvironment, that's actually going to calm down the immune system and actually promote immune surveillance, where there's little T cell activation, little migration to that area. And this has been associated with actually increased risk of malignancy. Having that adenosine-rich environment. In addition, adenosine can be uptaken into the cell and ultimately broken down into its components of inosine, hypoxanthine, and uric acid. And uric acid has actually been associated with increased risk of cardiovascular disease and mortality associated with cardiovascular disease. It's unclear if it's through this purinergic mechanism, but there has been some literature in the last few years that suggests that obstructive sleep apnea and increased intermittent hypoxia is associated with greater serum acid levels. In this one by 2014, they did find that there was some association between the AHI and serum uric acid, and this also seemed to be more prevalent in people with sleep apnea with cardiovascular events as compared to those without cardiovascular events. And so we would hypothesize that poor sleep health, whether it's due to obstructive sleep apnea or otherwise, will lead to an increase in ATP-related damage, thereby causing immune activation. With that increased ATP, we would imagine that there will be an increased amount of adenosine metabolites due to the increased substrate. Because of that, we would imagine that in order to compensate for the increased ATP burden, there might be an upregulation of CD39, an upregulation of CD3 and ultimately an increase in adenosine metabolites in people with poor sleep compared to those without. And so in order to investigate this, we are recruiting participants both with HIV and without HIV and having them undergo a sleep phenotyping protocol. And we divided the group into 4 groups: people with HIV without a sleep disorder, people with HIV without a sleep disorder, with a sleep disorder, people without HIV with a sleep disorder, and people without HIV with a sleep disorder. And so in this data that I'm going to show you now, we took a look at the presence and absence of obstructive sleep apnea, which we defined as the AHI 4% greater than 5 events per hour. And this was assessed with the WatchPat device, 1 night of WatchPat. Again, the people with HIV who were included in this study were on stable antiretroviral therapy, who had very well constituted CD4 counts, at least greater than 250, and who did not have any evidence of viral suppression at the time of enrollment. And so you can see here, we roughly had 77 people in the people without HIV group and 81 participants in the people with HIV group that were relatively equal throughout. Everyone tended to be in the middle age group, and we did have a preponderance of men that we recruited into the study. There was more participants of Black background in the people with HIV. But overall, this was a non-sleepy cohort. We did ask participants to report their caffeine use, as caffeine can certainly affect levels of adenosine in the body. And so when we took a look at the proportion of T lymphocytes that were positive for CD39 and positive for 73, we didn't see any meaningful differences between the people with sleep apnea and without sleep apnea by HIV status. On the left, you can see here the people without HIV group. There was a similar amount of CD8 positive CD4 T cells, as well as CD4 positive CD8 T cells by OSA group. Similarly, CD73 was the same. And if we take a look at the people with HIV, they had similar proportions to those without HIV, although there may be a signal towards lower CD73 positive CD8 T cells generally in the people with HIV group, despite OSA exposure. Similarly, when we took a look at CD39 expression on those cells that were CD39 positive, we didn't see any difference in expression rates by lymphocyte. We measured the expression of CD39 by the fluorescent intensity, and what the median fluorescence intensity was per participant. And so you can see here this gray portion of the figure highlights the median fluorescent intensity of the CD4 T lymphocytes by HIV group and sleep apnea exposure group. And these were very similar between the sleep apnea exposure, whether HIV positive or negative. And similarly, on the right side of this figure, you can see that although CD8 T lymphocytes had a lower rate of expression of CD39, that these were comparable by sleep apnea status despite HIV status. Now, interestingly, when we took a look at CD73 expression on those CD73 positive cells by OSA exposures, we did see a meaningful difference. And so here, when you take a look at the CD4 T lymphocytes, you can see that people without HIV who had sleep apnea, those people tended to have a greater amount of CD73 expression compared to those without sleep apnea. I will say that people with HIV didn't seem to have any meaningful difference despite sleep apnea exposure. And similarly, when we took a look at the CD8 T lymphocytes, we saw something similar to the CD4 T lymphocytes, where the people without HIV who had sleep apnea exposure had greater CD73 expression compared to those without HIV. Compared to those without sleep apnea. And in those who had HIV, they had similar levels of CD73 expression. And so overall, although we saw similar frequencies of CD39-73 positivity, in general, people without HIV had greater expression of CD73, both on CD4 and CD8 T lymphocytes, whereas in people with HIV, there was no substantial difference. And since we think that the expression of CD73 is associated with this increased extracellular adenosine, the inability of people with HIV to increase the expression of CD73 may suggest decreased ability to actually regulate this external ATP and adenosine. Now, then our next steps are to directly compare the adenosine metabolites by OXA exposure and HIV status, and we're in the midst of getting that data right now for analysis. All right, and I think we have time for me to kind of briefly talk about my work in monocyte activation, which will be the main topic of my career development award. And so monocytes are an element of the innate immune system that are constantly patrolling the peripheral environment in search of badness and damage. Overall, when a monocyte comes across an area of damage or stimuli, it will become activated and produce pro-inflammatory cytokines like IL-1 beta, IL-6, and TNF-alpha. It'll upregulate vascular adhesion molecules to adhere to the endothelium and eventually migrate into the vessel wall, where it can then differentiate into macrophages, engulf LDL, and become foam cells. There are 3 types of monocytes that occur in circulation. The most prevalent of which are classical monocytes that are CD16 negative. But with time and with exposure to stimuli, it can upregulate CD16, at which time it will become an intermediate monocyte, or ultimately become into a patrolling monocyte, which is kind of an older, more senescent kind of form of monocytes. And so what we see is that in people with HIV creates kind of a chronic monocyte dysregulation and an increased production of basal IL-1 beta and TNF-alpha, and a heightened production of IL-1 beta and TNF-alpha in response to stimuli, despite the level of HIV control. There's also greater differentiation of macrophages and foam cells, and it's been shown that people with HIV who have more frequency of intermediate monocytes or patrolling monocytes are at higher risk of cardiovascular disease than those with lower frequencies of CD16 monocytes. And that's similar to what we see in the HIV negative population. In the HIV negative population, there's been several trials that have shown that people who have an increased proportion of intermediate monocytes in circulation are at higher risk of having a cardiovascular event than those, and progressive cardiovascular disease, than those with lower proportions of intermediate monocytes. And so, like I said, there are a variety of ways of measuring monocyte activation. Those can include measuring soluble markers such as soluble CD14 and CD163, which is actually a macrophage marker. But also you can look at the monocyte phenotypes, so this preponderance of CD16 monocytes, the production of IL-1 beta, IL-6 and TNF alpha, as well as this upregulation of vascular adhesion molecules. And so there are a variety of ways that sleep apnea can also contribute to monocyte activation. And we do have several studies that have shown that both sleep deprivation as well as intermittent hypoxia do directly cause a monocyte activation. And I'll briefly go through that literature with you shortly. But it could be that monocyte activation can be heightened in sleep disorders by a variety of mechanisms, including oxidative stress, increased sympathetic activity, and other mechanisms that are summarized here. This was a fantastic study put out in the Blue Journal last year that showed both that sleep apnea exposure as well as intermittent hypoxia increase NLRP3 inflammasome activity in monocytes. And NLRP3 inflammasome activity is integral in the production and secretion of active IL-1 beta. The NLRP3 inflammasome is a trimeric protein complex that ultimately, when put together, activates a zymogen, procaspase 1, into its active form caspase 1. And that converts these inactive pro-inflammatory cytokines to their active form, one being IL-1 beta, but also including IL-18. And so if there is an increased amount of inflammasome activity, that is certainly a sign of increased monocyte activation and production of these pro-inflammatory cytokines. And so what they did is that they took monocytes from the peripheral blood, both of controls and of people with severe obstructive sleep apnea. They then took those monocytes and they exposed them to either normal oxic conditions or intermittent hypoxic conditions, and then evaluated them for NLRP3 presence and also for active caspase 1 presence. So on the left, you can see here that these bars in blue are from the controls. And those who had, and so those monocytes taken from the controls that were exposed to normal oxic conditions had, a reference level of NLRP3 activity. The monocytes from controls were also exposed to intermittent hypoxia, and you can see that there's quite a substantial increase in NLRP3 positivity after exposure to the intermittent hypoxic condition compared to normal oxic. When they took a look at people with obstructive sleep apnea, you can see here that even with normal oxic conditions just being taken from a person with obstructive sleep apnea, there was a greater amount of NLRP3 presence compared to controls, whether exposed to normal oxic or intermittent hypoxic conditions. And then even with the further exposure of intermittent hypoxia to sleep apnea, there was an even greater production of or presence of NLRP3 cells. Now, you can argue, well, maybe this is just a priming phenomenon, and NLRP3 being present isn't associated necessarily with the function of the NLRP3 inflammasome. A better way of measuring that would be active caspase 1 activity, because then you know that that zymogen is being cleaved. And here we do see a similar trend where controls who were exposed to the normal oxic condition have the least amount of active caspase 1 prevalence, and people with sleep apnea, monocytes taken from people with sleep apnea also exposed to intermittent hypoxia, had the highest levels of active caspase 1 cells. And they also show this for a variety of inflammatory pathways, such as an increased amount of HIF-1 alpha, as well as NF-kappa beta, which is summarized here. And then in addition to that, we are seeing emerging evidence that there may be a skew towards more CD16 positive monocytes in people with sleep apnea. This was a relatively small study put out a couple of years ago, but I thought that it was quite interesting that, especially since we haven't been able to really phenotype monocyte subsets in the presence of sleep apnea up until this point. And so you can see here that classical monocytes, these are, if I can direct your attention to this figure in the top right corner, the box in green here, the majority of monocytes are CD1 positive monocytes that are CD16 negative. And these are the classical monocytes. These are the majority of monocytes that are in the peripheral blood. And then above that, in the red box here, are intermediate monocytes, which are thought to be the most pro-inflammatory monocytes. And these are positive for CD14 as well as 16. And those that are in the pink here are patrolling monocytes, which are thought to be the last stage of monocyte longevity. And these have a lower amount of CD14, whereas they have an increased amount of CD16. And so if you look at the monocyte subset percentages by people without sleep apnea versus people with sleep apnea, you can see that in healthy donors without sleep apnea, there is the majority of cells, as expected, are classical monocytes with relatively low proportions of intermediate and patrolling CD16 positive monocytes. Whereas people with sleep apnea tend to have a lower amount of classical monocyte in exchange for greater percentages of intermediate monocytes, particularly, as well as patrolling monocytes. And although the percentages of these monocytes are different by person, overall, people who had severe sleep apnea tended to have more severe alterations of their monocytes in proportion. So the healthy donors, you can see this 82% is supposed to be the classical monocytes, whereas this 18% is the CD16 positive monocytes. And in people with sleep apnea, they tended to have more severe skews of these monocyte subsets in proportion, with even some people having less than the majority of their cells being CD16 negative classical monocytes in favor of this increased proportion of CD16 monocytes. And so we wanted to see, does sleep apnea in the setting of HIV worsen monocyte activation? As I told you, monocytes in people with HIV already have a level of monocyte dysregulation that's known. And so we want to see, does the superimposed stress of sleep apnea on top of people having HIV, does that worsen monocyte activation even further in this cell set that's probably vulnerable to more monocyte dysregulation? And so what we did is we took people with HIV and we sleep phenotyped them, both with the WatchPat home sleep study, as well as 14 days of actigraphy. And we took blood on the last day of actigraphy, and we evaluated them by their sleep apnea status. We tried to make sure that their sleep duration was similar between the two groups, although you can see that the people without sleep apnea did have a shorter sleep duration. But overall, you can see that people with HIV with sleep apnea tend to be more female, and also include people more of Black descent. And you can see that this is a bit of an older population compared to the max cohort. So I do want to point that out. But this is a small number that we've been able to get to thus far. But we are seeing that the intermediate monocyte frequency does appear to be higher in the people with HIV with sleep apnea exposure compared to those without HIV, without sleep apnea rather. And then when we took a look at the intracellular cytokine production of IL-1 beta, IL-6, and TNF-alpha, we also saw trends towards greater intracellular pro-inflammatory cytokine production in those people with HIV with sleep apnea exposure. These didn't meet statistical significance with the exception of TNF-alpha, and likely that's due to the small numbers that we've been able to get to thus far, but it certainly is an interesting finding right now, and we'll be going through this data with the remaining 160 people. And so my takeaway points here is that sleep disturbances are extremely prevalent and clinically significant in people with HIV and shouldn't be just limited to increased prevalence of sleep apnea, but really should be really comprehensive in evaluating sleep disturbances from a variety of viewpoints of all the dimensions of sleep health. There are several biological pathways that are common to both sleep disorders and HIV inflammation, but it's been relatively understudied if there's synergy between those biological pathways in the increased non-AIDS comorbidity risk that we're seeing in people with HIV with sleep disorder. And so I think that there's a lot of different avenues to explore in order to clarify the contribution of sleep disorders and HIV-associated inflammation and HIV-associated comorbidity risk. And with that, I'll take any questions that you may have. Thank you so much for your time, everyone.